All right. Hello, everyone. Thanks so much for joining this session. My name is Thomas Mawson. I'm a cardiologist at Columbia University Irving Medical Center. And today I'm going to be talking to you about atrial fibrillation management, which I think is an exciting topic because this is something that has been evolving a lot in recent years. I have no disclosures. This is an outline of some of the topics I'm going to focus on, and I want to place particular emphasis today about rate versus rhythm control strategies, because this is something that has continued to evolve, as well as stroke prevention. I'm not going to talk about diagnosis or initial evaluation. All right, so I think everyone knows that atrial fibrillation is extremely common. It's the most frequent sustained arrhythmia in adults. It's something that increases in prevalence with age, and so it's particularly relevant in geriatric populations. It's present now in probably over 9% of individuals by age 80, and it conveys an increased risk of stroke, of mortality, as well as having serious detrimental quality of life impacts, and can also contribute to structural heart disease and heart failure. Um, the increases in prevalence of AFib that have been seen can be attributed both to our aging population, as well as the increased prevalence of other comorbidities that are associated with AFib. Guidelines that are most relevant for today, if anyone wants to look at these more closely, are the 2023 ACC-AHA and Heart Rhythm Society guideline for the diagnosis and management of AFib. And so, as I mentioned, the prevalence of AFib continues to increase. It's extremely common. There are a number of comorbidities that are associated with atrial fibrillation, both in terms of association with the presence of AFib and also potentially associated with stroke risk. There are a few classifications of AFib that are important to distinguish. We distinguish between paroxysmal AFib, which refers to really when someone is in and out of sinus rhythm with just brief episodes of atrial fibrillation. When an episode lasts for over 7 days, we say they have persistent AFib. When an episode lasts for over a year, we call it long-standing persistent AFib. And permanent AFib really reflects a decision by the provider to no longer try to maintain or achieve sinus rhythm. Permanent AFib is someone who's just in AFib all the time. And as we'll see, AFib tends to beget more AFib. And the longer someone is in AFib, the less likely they are to be able to go back into sinus rhythm or to stay in sinus rhythm. AFib is a chronic progressive disease in patients who have paroxysmal AFib, which again is when they're having episodes of AFib that they're in and out of. The percentage tends to increase over time. And after someone has been in AFib continuously for years, it becomes much less likely that you're going to be able to put them back into sinus rhythm. This is because atrial fibrillation causes remodeling of the tissue and the electrical system in the atrium, and that can disrupt the electrical tissue. It can also increase the risk of structural heart disease. Oftentimes in atrial fibrillation, we see that when patients are put back into a normal heartbeat, they may have a slow or diseased sinus node, which can lead to a condition sometimes called tachybrady syndrome, where people are fast when they're in AFib and slow, sometimes symptomatically slow, when we put them back into sinus rhythm. Atrial fibrillation, as I've alluded to, has a number of deleterious consequences. One, there are the hemodynamic effects. You can have rapid ventricular rate. You lose the atrial kick from having synchronized contraction of the atrium, just wobbling, fibrillating atrium. There's an increased risk of stroke, generally due to thrombus forming in the left atrium and especially the left atrial appendage. That also conveys a risk of systemic embolism to other parts of the body. Um, AFib can cause symptoms, both through heart failure symptoms and through symptoms just like dyspnea, fatigue, often subtle symptoms that sometimes patients don't even recognize until they are restored to sinus rhythm. AFib is a marker of adverse outcomes. We know that it's associated with mortality when it's present, regardless of age. And I think in thinking about why a patient presents with AFib, it's important to distinguish between causes and triggers. Patients may be more likely to be in AFib in the hospital when they're infected, when they have a high sympathetic tone, when they're doing vigorous physical activity, when they are consuming a high amount of alcohol. But a lot of the triggers are not necessarily underlying causes. Oftentimes, attention to both triggers and causes can determine the success in maintaining sinus rhythm. Atrial fibrillation is associated with a number of different comorbidities. I want to especially highlight obesity and sleep apnea because these are areas that are often, uh, sleep apnea in particular, is often underdiagnosed. It can be a reason patients may be refractory to attempts to restore sinus rhythm. And obesity, as well as sleep apnea, we have increasing opportunities for treatment with GLP-1 agonists. And we see patients who, when their sleep apnea is adequately addressed, when they lose weight, their burden of AFib may decrease, their symptoms from AFib may decrease. And that's something that's key to think about when you initially evaluate a patient with atrial fibrillation. There are a variety of goals for atrial fibrillation, and those goals are going to be individualized, especially in a geriatric population. In certain patients, you're looking to improve their survival, and as we'll see later, some therapies for AFib may have a mortality benefit. You want to especially reduce the risk of stroke and systemic embolization. You want to hopefully reduce the risk of developing clinical heart failure. We want to reduce hospitalizations related to AFib, and we want to improve symptoms and quality of life. The way that we achieve that and what are the most important goals, again, depends a lot on the patient and on the risks and benefits of specific therapies. Now, one of the biggest topics that I want to focus on is rate versus rhythm control. Um, and for a long time, the paradigm for this was pretty straightforward, and it was something that you would expect a medical student to know, which is that rate control is just as good as rhythm control in most people, and you just want to rate control them to less than 110. As we'll see, that paradigm is actually getting a little bit more complicated now, and we're recognizing much more the benefits of rhythm control, and we're getting much better therapies to achieve rhythm control. Now, what are some of the specific strengths and limitations by that? Now, when I say rate control, I mean accepting that the patient is in atrial fibrillation, either some or all of the time, just ensuring that the ventricular rate is not going too fast. Oftentimes, preventing rapid ventricular response or tachycardia can improve rate-related symptoms, and it can often help with adverse hemodynamic effects of rapid ventricular rate, particularly in patients with structural heart disease. You'll see patients who come into the emergency room hypotensive or dizzy in AFib with a rate of 150, and then you rate control them, you get their ventricular rates down to the 90s, and their blood pressure improves, they feel better. What are the limitations of rate control? Some patients will continue to be symptomatic with any AFib, even if they're in AFib with a ventricular rate of 70. Some people are very symptomatic in AFib and they can tell you exactly when they go into AFib. The other effects are more related to the fact that the patient is still having AFib. So all of the adverse remodeling of the atrium, of the electrical system, the dilation of the left and right atrium that you get, that will continue when the patient is in AFib. Furthermore, as I mentioned earlier, the more AFib you have, the more likely you are to remain in AFib, the higher your burden will be. So you may have a patient who maybe when you first meet them, they don't have significant structural heart disease, they're not having a lot of symptoms. You think, I'm just going to rate control them. Then they're spending a lot of time in AFib, they have a high burden, and let's say some years down the road, they develop other structural heart disease, in which case you might want to rhythm control them. Well, now you're not going to be able to because the patient has been continuously in AFib for years. Let's talk then about rhythm control. Rhythm control, you're actually trying to restore and maintain sinus rhythm. Minimizing the burden of AFib or hopefully eliminating AFib completely. Now, that can be very effective for symptoms, both related to rapid ventricular rate and also just symptoms directly from being in AFib. There are also hemodynamic benefits from being in AFib, both in terms of in the moment and long-term effects on cardiac structure. And it can prevent some of that remodeling that we see in atrial fibrillation. Now, what are the limitations? Sometimes patients, despite aggressive attempts to rhythm control them, continue to have AFib. It's just not effective. Particularly antiarrhythmic drugs can be associated with significant toxicities and can sometimes promote other arrhythmias. Invasive therapies like catheter ablations can be associated with procedural risks. And rhythm control does not necessarily eliminate that risk of thromboembolism. Now, this is a little bit controversial and something that's in flux. Part of the reason that we say this is because ablation historically has not been 100% effective. Historically, ablation was about 50 to 70% effective, depending on who did it. And that risk of recurrent AFib would convey the risk of thromboembolism. If you had a procedure that was 100% effective, presumably that would eliminate the risk of thromboembolism. So as I alluded to earlier, there's sort of an older landscape or paradigm of rate versus rhythm control, and there's a newer one which is rapidly evolving. The older landscape was based in large part on the AFFIRM trial, which was done in 2002, before catheter ablation was widely used, and was based on rhythm control with antiarrhythmic drugs. And the takeaway from that trial really was that rhythm control wasn't any better than rate control, and there was actually a trend towards harm, probably related to some of the adverse effects of rhythm control drugs. And then there are data from the RACE-2 trial showing that rate control to under 110 was sufficient, that there was not a benefit to more aggressive rate control. Now that's the older landscape. The one line takeaway for the older landscape is rate control is just as good as rhythm control. The newer landscape is that catheter ablation is becoming much more widely used. The technologies for catheter ablation are rapidly evolving, and the utilization is rapidly evolving. Providers, electrophysiologists are getting better at catheter ablation, and the technologies are becoming safer. And we're gradually accumulating more and more evidence that it is beneficial to achieve rhythm control and maintain it if you can, both in patients with and without clinical heart failure. So these are data from the AFFIRM trial, which, as I mentioned, was published in 2002. And the key thing I want to mention, because this is a widely cited trial, is rhythm control in this trial meant antiarrhythmic drugs. And as you can see, there's a trend towards actually higher mortality in the rhythm control group, probably related to the risk of sudden cardiac death with certain antiarrhythmic drugs. So, taking a step back, focusing on rate control. How do we achieve rate control? We do this by decreasing the number of atrial signals that get through to the ventricle. The intrinsic rate in the atrium is hundreds and hundreds of individual signals going off, and we want to block many of those from getting to the ventricle. We do that generally with beta blockers or calcium channel blockers, sometimes with digoxin, although this is a little bit more controversial. These AV nodal blocking agents, first line is generally going to be beta blockade. Metoprolol is probably the most widely used because it is not a very good antihypertensive. It has the least effect on blood pressure compared to, say, carvedilol. The dosing and frequency is going to depend on what the patient tolerates in terms of symptoms and blood pressure, and what achieves rate control. We especially want to use beta blockers in patients who have another indication based on, say, ventricular dysfunction. Now, that's important because calcium channel blockers, such as diltiazem or verapamil, are associated with increased risk in patients with ventricular dysfunction. So we generally avoid calcium channel blockers like diltiazem for rate control in AFib patients with a low EF. Part of that is related to the negative inotropy, the negative effects on contractility of calcium channel blockers. Calcium channel blockers like diltiazem can be a little more potent, both in terms of rate control and sometimes their effect on blood pressure. They also may not have some of the same risks in terms of bronchodilation and bronchoconstriction that we see with beta blockers in patients with COPD. Both of these, beta blockers and calcium channel blockers, are widely used and perfectly effective drugs for rate control in the appropriate patient. Digoxin is a little bit more controversial, and how much it's used depends a little bit where you practice, how comfortable you are with it. Mainly because of the balance of risk benefit compared to other agents. Digoxin has a little bit of a positive inotropic effect, and it's still a drug that's being studied and fully understood in a heart failure context. It also has effects on vagal tone that slow transconduction through the AV node and can be effective for rate control. It should not lower blood pressure. And so sometimes we'll see it used in heart failure patients with a somewhat tenuous hemodynamic status, and people aren't comfortable giving a patient a beta blocker or a calcium channel blocker for short-term rate control, and they turn to digoxin. The main issue with digoxin is the risk of toxicity. It has a narrow therapeutic window, particularly in renal dysfunction, both AKI and CKD, which are obviously quite common in geriatric patients. What are our goals with rate control? Ideally, we want to have the average heart rate under 110 beats a minute, including with moderate exertion. And so the goal is not that, the average heart rate is 109. The goal is that we're preventing excursions over 110, even with exertion. Now, let's turn back to rhythm control, because this is, I think, where a lot of the investigation currently is going. What are the situations where rhythm control is more preferred? Well, obviously, people who continue to have symptoms despite effective rate control, you're going to try to put them back in sinus rhythm. In patients who you can't adequately rate control them with medications, you'll see patients who are on the maximum dose of diltiazem, or they're on both a beta blocker and a calcium channel blocker at high doses, and they're still having sustained high rates. You want to put them back into sinus rhythm to prevent tachycardia, induced cardiomyopathy, and adverse hemodynamic consequences. Generally, when someone has their first presentation of AFib, you're going to try to put them back in sinus rhythm. Now, that may just mean doing a cardioversion and then monitoring them. It doesn't necessarily mean procedures or antiarrhythmic drugs, but that's something, again, where the evidence is a bit in flux. Very young and very elderly patients, oftentimes rhythm control is pursued. For younger patients, that's because the idea is they have the most to benefit from maintaining sinus rhythm because of the adverse consequences of many years of remodeling in AFib. With older patients, the idea is that some of the adverse effects of antiarrhythmic drugs, such as amiodarone, are going to be less significant compared to the benefits of rhythm control. And then oftentimes patients with heart failure or other structural heart disease are going to benefit from being in sinus rhythm based on the hemodynamic benefits. This is something that is very individualized, and what this looks like is going to depend on the patient. It's going to depend on the center that you're at, the other providers that you're working with. Individualization is the key word here. Now, what does rhythm control look like? The quickest and most straightforward way to rhythm control someone is by cardioverting them. You do a synchronized cardioversion, you put them back into sinus rhythm. The key thing is that is not a long-term strategy. That does nothing to prevent the recurrence of atrial fibrillation. It is purely a one-time measure. And you'll see patients who they have a low burden of AFib. They get cardioverted maybe once every 1 or 2 years. and that keeps them in sinus rhythm for a number of years. Now, some patients, particularly when they have been in AFib for longer, if they have persistent or or especially long-standing persistent AFib, they may need to be on an antiarrhythmic drug before a cardioversion for the cardioversion to be successful. So you will see patients who get loaded with amiodarone for a week or a few weeks, and then after a month of amiodarone, they get a cardioversion. And then if it's successful, their electrophysiologist may decide if they keep them on amiodarone. The growing strategy for rhythm control is catheter ablation. And this is something that I'll talk about more that is rapidly evolving. Let's start with antiarrhythmics. The key thing to stress about antiarrhythmics is that all of them have significant adverse effects profiles. There is no one antiarrhythmic that is quite safe and quite effective, and you don't have to worry about comorbidities. They all you have something that you pay a price for. Generally, an antiarrhythmic is, particularly for some of the less common ones, going to be managed by an electrophysiologist or at least a cardiologist. This is if you're not a cardiologist, this is not something that you should have to be managing alone. I'm just going to mention two briefly because they are the most widely used. Flecainide is a class 1 antiarrhythmic, a sodium channel blocker that is quite effective. There are patients who use it both long term and actually use it just when they get AFib, what's called a pill in pocket approach. The main limitation we run into is it is not safe to use in patients with coronary disease or with structural heart disease, which is a big proportion of patients with atrial fibrillation. Often, if a patient is going to be started on flecainide, they will need some form of ischemic testing, like a stress test first. They will also need to be on a rate control agent like a beta blocker. Amiodarone is probably the other most widely used antiarrhythmic. It has a variety of physiologic effects. It's a sodium channel blocker, it's a potassium channel blocker, it's a beta blocker, and it is very effective. It's widely used. The main issues are the risks of toxicity. There's a risk of short-term toxicities like thyrotoxicosis. This is relatively uncommon, but the longer a patient is on it, the higher the risk becomes for other toxicities, particularly pulmonary toxicity. If a patient is on amiodarone for years and years, at some point, they're probably going to get pulmonary toxicity from the amio. And so there is baseline blood work and monitoring that you want to get, and then patients will require continued monitoring when they're on amiodarone, such as LFTs and TFTs at a minimum once a year, once they've been on it for a while. Now, I want to talk about one trial in relation to rhythm control because this is a trial that was mostly antiarrhythmics. East AFNAP 4 was a New England Journal paper that came out in the last few years. It was done in Europe mainly. It was 2,789 patients with quote unquote recently diagnosed AFib defined as a diagnosis within the past year. And all of the patients were either over 75, they'd had a prior stroke or TIA, or they had two other risk factors. And this included an age over 65, hypertension, diabetes, left ventricular hypertrophy, CKD, severe coronary disease, and a couple of other things. And they were randomized to either rhythm control or usual care. If you look at the breakdown, most of the rhythm control up front was with antiarrhythmics. The patients who got ablated up front was less than 10%, and the most commonly used antiarrhythmic in this trial was flecainide. And they showed actually a reduction in their composite endpoint, and they showed significant reductions in the individual components of cardiovascular death with a hazard ratio of 0.72 and stroke with a hazard ratio of 0.65. I think at about 2 years, about 20% of the patients had ended up getting an ablation, but still, this was not primarily an ablation trial. It was a rhythm control trial, suggesting a benefit to early rhythm control, even in a population where the average age was about 70. Now let's talk about catheter ablation. Now, what does that actually mean? The idea is that when a patient has atrial fibrillation, certain areas of the atrium are sort of the problem spots. They're the areas that are more likely to give off these abnormal signals. Certain areas of the atria we know are more likely to be the source of atrial fibrillation, particularly around the insertion of the pulmonic veins into the atrium. And what is done with the catheter ablation is to essentially go in and eliminate those areas by either applying radiofrequency ablation, pulsed field ablation, or cryoablation to eliminate or isolate from the rest of the atrium those problematic areas. This is something where the technology is rapidly evolving. Pulse field ablation, which has become increasingly used, is sort of the newest kid on the block. But the technologies that are used will depend a lot on where you're practicing, a specific operator, variety of other things. And both the use and the evidence base for this continues to evolve rapidly. And what we're seeing is that people are getting better at it. They're getting more comfortable with it. The risks seem to be decreasing as people get better and the technologies improve. And we're seeing increasing evidence of benefit. What is done basically, also I should mention, or there is venous access. The catheters are then going to go uh, through the right atrium, across the intraatrial septum into the left atrium, and then using these catheters, the electrophysiologist will map the electrical system, and then they will ablate certain areas. And that could be a straightforward pulmonary vein isolation, or it could be multiple other kinds of ablation. And so when you see patients getting repeated AFib ablations, often they're getting different approaches depending on the mapping that's done during the specific procedure. Now, there's a couple somewhat recent ablation trials that I want to highlight. Again, suggesting some of the benefits. In the heart failure space, Castle AF was a trial that was published now about 7 years ago, looking at catheter ablation in 363 patients with heart failure with reduced ejection fraction, who were NYHA class 2 to 4. Now, these were all patients who had previously gotten antiarrhythmic drugs and either didn't tolerate them, the drugs didn't work, or the patients just refused to take them. So it's in a somewhat selected population. In that population, who all had clinical HFrEF, there was a reduction in the composite of all-cause mortality or heart failure hospitalization with ablation compared to medical therapy. Now you can see if you go out about 4 years, there's still a significant number of endpoints in the ablation group, but it is a pretty significant reduction with a hazard ratio of 0.62 compared to medical therapy. There was a more recent trial that came out about 3 years ago called Castle HTX that looked specifically at end-stage heart failure, which you might theorize these are going to be patients too sick to benefit, but they actually showed a significant reduction in mortality, actually, with catheter ablation. The other trial I want to highlight in the non-heart failure side is the early AF trial. This was using a specific ablation technology called cryoablation and comparing it to antiarrhythmic drugs. And in about 300 patients with symptomatic paroxysmal AFib, there was a significant reduction in recurrence with catheter ablation compared to antiarrhythmic drugs, suggesting that ablation may be more effective than antiarrhythmic drugs and without carrying a lot of the adverse side effect profiles of antiarrhythmic drugs. The hazard ratio was actually 0.48, which is quite impressive. Before I go on to stroke prevention, this can be quite nuanced, thinking about the risks and benefits of catheter ablation. And again, a lot will depend on an individualized assessment of your specific patient. It'll depend on the skills and comfort of the electrophysiologist you're working with. It'll depend on how long the patient has been in atrial fibrillation and really what you're expecting to achieve. Let's move on now to stroke prevention. This is something that, whether or not you pursue a rate or rhythm control strategy, you need to have separate treatments for stroke prevention. The current evidence and the current guidelines is that even if a patient has an apparently successful ablation or is effectively rhythm controlled on a drug, you still have to treat them with an anticoagulant or other option to reduce the risk of stroke. And that is because of data showing that, these rhythm control strategies are not 100% effective. And you may not know when a patient goes back into AFib, and they could have a fatal or disabling stroke when that happens. So, in thinking about stroke prevention, first up, it's key to distinguish quote unquote valvular from non-valvular AFib. And what that means is not, does the patient have valvular heart disease? Do they have MR or TR? It's really, do they have moderate to severe mitral stenosis or a mechanical heart valve? That puts them in a completely separate bucket in terms of treatment. All other atrial fibrillation, for the most part, quote unquote non-valvular, you're going to use a validated risk score to think about their anticoagulation. The most widely used one by far is the CHADS2 VASC. And what you do generally is anticoagulate if the CHADS2 VASC is at least 2 in men, at least 3 in women. And I would say often you're going to anticoagulate for 1 or more or 2 or more in women. Sometimes you will see even patients anticoagulated with a CHADS2 VASC of 0, but that's a little bit more of a risk-benefit discussion. There are also expanding options in the device space for stroke prevention. I'll talk more about what this involves. The most commonly used one now is something called a Watchman. Now, just to reiterate this point, valvular AFib is a separate bucket. This refers to moderate to severe mitral stenosis or a mechanical valve. You're always going to anticoagulate these people. You are not going to use a CHADS2 VASC. And you're also not going to use a CHADS2 VASC for patients with hypertrophic cardiomyopathy or cardiac amyloid. Again, that completely separate in terms of stroke risk, thought to be related to the myopathy of the atrium and the flow dynamics within the atrium. Now, for your garden variety non-valvular AFib patient, DOACs such as apixaban, rivaroxaban, dabigatran are widely used. They're almost universally preferred over warfarin in your standard non-valvular AFib patient. This is because of ease of use. You just start the drug. It doesn't require monitoring of a therapeutic level like an INR. The patients should be therapeutic as long as they are taking the drug, compared to a lot of data, even from trials, showing that patients in Coumadin are only in therapeutic range maybe 50% of the time, and that's in a trial. And multiple trials have indicated significantly less bleeding with DOACs compared to warfarin, including major bleeding like intracerebral hemorrhage. And you also don't have some of the same dietary limitations that you have with Coumadin, where patients have to worry about their intake of certain greens and vitamin K containing foods. The notable exceptions for this are, as always, mechanical heart valves. Every study that has tried to look at, can we safely use DOACs in mechanical valve, doesn't seem to be as effective as Coumadin. Rheumatic mitral stenosis, you are going to use Coumadin, and patients with antiphospholipid syndrome are another notable exception where Coumadin is preferred. The one other thing I'll mention is the patient that maybe has been on Coumadin for many years and just has regular non-valvular AFib. Is it better to switch them to a DOAC? That's actually a little bit controversial. There's some data that suggests maybe not. I'm not going to get into that right now. Now, other than anticoagulation, the other option is what's called left atrial appendage occlusion or closure. And the most widely used devices are the Watchman and the Amulet. When a patient is in atrial fibrillation, we think about their risk of forming thrombus within the left atrium. The left atrium is barely moving, it's fibrillating, there's increased stasis, and that leads to increased risk of thrombus formation. And that's particularly likely to happen in this little outpouching of the left atrium called the left atrial appendage. This is an area of especially low velocity flow where over 90% of clots form. And when we check inside the heart on transesophageal echocardiography prior to a cardioversion, this is the area we're most interested in ensuring that there's no clot. So what do these devices do? Basically, we go in with a catheter and we put in a plug to exclude this area from flow or to cinch it off. And that can either be done transcatheter or it can be done during cardiac surgery. The surgeon can ligate or place a clip around the left atrial appendage, although that is not always 100% effective. This is one way of ultimately facilitating discontinuation of anticoagulation. You are putting a foreign body into the heart directly in contact with blood. So if a patient, say, is on a DOAC, they're generally going to have to remain on the DOAC for several months afterwards until you can confirm with imaging that left atrial appendage occlusion has been effective and there's no clot on the device, there's no residual flow around the device. And if that's the case, then you can stop the anticoagulant. This has been most studied in patients who, for one reason or another, it's more risky to be on an anticoagulant due to increased bleeding risk, or also you'll see this in patients maybe who are high fall risk, and you worry about the risk of intracerebral hemorrhage on anticoagulation. The oldest data actually going now back to about 2005, 2006 in the Protect AF study are looking at these patients who are higher risk on anticoagulation or maybe have a contraindication to anticoagulation. More recently, it's an area of much greater interest and controversy has been occlusion just based on patient preference, patients who want to stop anticoagulation, or after catheter ablation. If you do an ablation that is apparently effective and then put in a Watchman immediately afterwards, is that a safe alternative to long-term anticoagulation? The most recent data that I want to highlight are the option trial, which was just published within the last year in the New England Journal. This looked at Watchman implant after atrial fibrillation ablation compared to anticoagulation. Now, their endpoints are important to note because they focused on non-procedural bleeding. They showed a pretty impressive reduction in non-procedural bleeding that was statistically significant with a hazard ratio of around 0.44. They also actually showed numerically less major bleeding overall, including procedural bleeding, but that did not reach statistical significance. They also showed non-inferiority with Watchman compared to AC for a composite endpoint of death, stroke, or systemic embolism, with numerically fewer events in the Watchman group. Now, this is all relatively short follow-up compared to, for say, a patient who is 70 and might be expected to be an AFib or might be expected to be followed for 15 or 20 years of life afterwards. This is an area that is highly controversial and the evidence base is continuing to evolve. But these are sort of what people are exploring in the field right now. All right, that concludes this presentation. I want to thank everyone for their attention, and I hope this has been a stimulating discussion of atrial fibrillation.